It's a great pleasure for me to introduce my friend, Professor Manuela Simoni from Endocrinology and Metabolism Unit, University of Modena. She will deal with endothelial dysfunction in multimorbidity. Please, Manuela.
Thank you very much. It's a pleasure to be chaired by you, Giovanni. This is a huge topic, and I decided to focus on the few things about this topic I know. First of all, let me acknowledge the contribution of my collaborator, Dr. Daniele Santi, who is the producer of the own data that I am going to show you today. These are my disclosures. I have nothing to say about conflict of interest. And when I saw the program of this conference, I was pretty intimidated by this parterre of pneumologists. I know nothing about BPCO. I'm just a humble endocrinologist. And the only reason why I'm here, I think, is because I am an academic colleague of the new department Leo Fabbri is leading. So he wanted to be kind to me. Thank you. This is the short outline of what I will tell you today. It's all about nitric oxide, endothelial function, at least the way an endocrinologist sees it. So I will say a few words about nitric oxide in endothelial function and dysfunction and in chronic diseases, because I think this could be a common denominator of many chronic diseases, and it's important in multimorbidity. I will touch upon PDE5 inhibitors and heart, and then go to the role of PDE5 inhibitors in diabetes, and then summarize and close up. I should say, and to further point out, that I am an endocrinologist with special interest in reproduction and in male reproduction. So this is something quite apart from COPD and asthma and all these nice things that I learned today. So if we talk about endothelial function, to be very simple, the function of the endothelium is to maintain the homeostasis between the blood and the arterial wall. And the dysfunction then is when the endothelial cell is not working normally, and there is, in the end, an impaired vasodilation. So it's all about nitric oxide, as I told you, and this is one picture that shows you the central role of nitric oxide in the function of the endothelial cells as a response to vasoconstrictors. You will have an increase in endothelial calcium concentration with an activation of the nitric oxide synthase, production of nitric oxide, which then in the smooth muscle cells below the endothelial cell will increase the production of cyclic GMP, and cyclic GMP is the motor of relaxation of the smooth muscle cells, so of vasodilation. This is probably all known to you, but it is interesting and important to remember, because this is the basis of our experimental data. The basis of endothelial dysfunction, there is oxidative stress, and as you can see here, many diseases, chronic diseases, typical of multimorbidity, lead to oxidative stress: metabolic syndrome, insulin resistance, diabetes mellitus, dyslipidemia, smoking, which is so close to your heart, aging, and hypertension. And the consequence thereof is the endothelial dysfunction, which consists in vasoconstriction, atherosclerosis, and thrombosis. And the first symptom of this syndrome is in men erectile dysfunction. There was a mediatic campaign promoted by the Italian Society of Medical Andrology and Sexual Medicine a few years ago, called I say it in Italian, impotenza che fortuna. So what a luck to have erectile dysfunction, which sounds a little bit strange, but it depicts very well the concept that erectile dysfunction is the first sign in a man of arteriosclerotic disease, if you want, and precedes cardiovascular symptoms of several years. So you should care about your decrease in sexual potency. What is the role of phosphodiesterase 5? So if you have an endothelial cells which produces nitric oxide and produces cyclic GMP, this produces relaxation and vasodilation. Phosphodiesterase 5 is the enzyme which breaks down cyclic GMP, and the role of PDE5 inhibitors is to inhibit the action of PDE5 and thereby increase the cyclic GMP and repristinate relaxation and vasodilation. This is the mechanism which is working in the penis, but is working also in the rest of the small arterial district. Phosphodiesterase 5 inhibitors, as you may remember, they were originally developed after the discovery of the importance of the nitric oxide to study drugs potentially important for heart diseases. But then the first clinical trials demonstrated an important side effect of phosphodiesterase 5 inhibitors, which didn't work that well for cardiovascular diseases. And in 1998, sildenafil, Viagra, as you may know it very well, was the first PDE5 inhibitor approved for erectile dysfunction. So the PDE5 inhibitor moved away from the field of interest of cardiovascular medicine and entered the interest of endocrinologists, urologists, and more in general, andrologists. This was the end of research of the role of PDE5 inhibitors in ameliorating many other aspects of small artery dysfunction. Why? Because immediately Viagra became a blockbuster. Everybody started to using it. Of course, the gentlemen here in this room over 50 will never admit to have used ever a PDE5 inhibitors, but I hope all of you did, and if you did not, you should start doing, because your wife will realize the difference. Not only the women in the room tend to clap. But this is an important point, because these drugs have been confined to the use in erectile dysfunction, preventing the study of their potential in other important diseases. After that, there were many others. I mean, in 2002, tadalafil, in 2003, vardenafil, and then there was finally the approval for pulmonary hypertension. Now they are under study for several other diseases. We don't know much about their role in women. This is a very nice example of gender-specific medicine, if you want, but there is no reason why they shouldn't be important also for in females. And the last in the family is avanafil, again for endocrine erectile dysfunction. Just a few words about the potential role of PDE5 inhibitors in the cardiovascular medicine. You see on the left-hand side animal studies, and on the right-hand side human studies. And you see that the animal studies are many more, and the human studies are very little and very conflicting, because conducting clinical studies with these drugs is of no interest for drug industry anymore these days. So although you don't like meta-analysis, I understand that, because you are dealing with thousands of patients in the field of pneumology, and you are dealing with enormous industry-driven trials. In this field of medicine, what people interested in pathophysiology as a basic mechanism for understanding the mechanism of diseases is very difficult to conduct trials, and so we are dealing really with only investigator-started trials and with low numbers. As you can see, there are conflicting results, no clear clear-cut effect on ischemia and myocardial infarction. But if we focus on endothelial dysfunction, again, there are some data in the animals suggesting good effect on that population, subpopulation of monocytes, which is anti-inflammatory. But the only factors that seems to be improved by endothelial function in humans is flow-mediated dilation and a reduction of interleukin-6. Let's turn for a moment to diabetes mellitus. Diabetes mellitus is, internists say it's an internistic disease. I tend to say it's an endocrine disease, but doesn't matter. It is characterized by three important symptoms: hyperglycemia, or not signs, not symptoms or facts, free fatty acid increase, and insulin resistance. All this ends up with an increased oxidative stress, and the result of oxidative stress is a vasoconstriction, inflammation, and thrombosis. And as you can see, the endothelium plays an important role there, and the reduction of nitric oxide availability is at the basis of all these problems. So, not only this, but also we know that the endothelial cell expresses the insulin receptor, and in case of insulin resistance, then you will have that also by this mechanism there will be a decrease of nitric oxide availability and of cyclic GMP production and accumulation, and vasoconstriction as a consequence. Animal models are important in this field. As I told you, I haven't seen any animal study today here presented, because obviously you have thousands of patients and enormous clinical trials available. We don't have that, so we have to turn to animal studies. And as you can see here, this is an animal model of diabetes. It's the streptozotocin treated rat, which develops type 1 diabetes. And if you perform a pre-constriction of the artery by acetylcholine, and then you increase the concentration of sildenafil that you give to these rats, you will have a reduction of the preconstriction, so a vasodilation, which is dose-dependent with sildenafil. And if you use an inhibitor of NO production, this inhibition is less evident, demonstrating that sildenafil increases and improves NO production. Also at the molecular level, you will see that there is an increase in the expression of this factor here, which is a cofactor of the NADPH coenzyme, which is important for the production of nitric oxide. You see it quantified here, and if you give sildenafil, you nicely reduce this overexpression, and thereby you increase nitric oxide production. Finally, very impressive, if you look at the arteries, you see here, this is the superoxide production, which, you know, the free radical oxygen species, which are counteracting the NO activity. If you have the streptozotocin rat, you will have an increase in this, in the luminosity of this superoxide marker here. And if you give sildenafil to the rats, this is quantified over here, up here, you will have a relaxation. So there is enough data in animals suggesting that if you use a PDE5 inhibitor, you can produce vasodilation, and it's a systemic vasodilation. This was not penis, this was just arteries. Now, if we want to measure endothelial function, what should we measure actually? We don't have many parameters available. We have hemodynamic parameters, which can be measured by echosonography, like flow-mediated dilation or intima media thickness, arterial stiffness, and peak systolic velocity. And we have a few biomarkers which are extremely controversial. You should expect a reduction of vasoconstrictors and inflammation markers. All of these have been variably used to measure endothelial function, but with very conflicting results. As I said, what we have to turn to the literature to understand what we should measure if we want to analyze endothelial function. I I'm introducing the study that we have just finished in diabetic men, because we were looking for parameters of endothelial function in men using PDE5 inhibitors. So looking at the controversial literature that exists on this topic, we ended up with the analysis of only 6 placebo-controlled randomized clinical studies with a very low number of patients which were treated with PDE5 inhibitors, actually only sildenafil. And actually what we could show in this small number, look here, of patients is a significant reduction of FMD and a significant, increase of FMD and a significant reduction of interleukin-6 in serum. But the low number of patients treated and the high heterogeneity do not allow to draw any conclusion. This is a picture of the phenomenon I told you before, that there are very few studies and very few clinical studies. So for us, the question was, is it possible to improve systemic endothelial function in men with diabetes type 2 by chronic use of PDE5 inhibitors? Because it is known that it improves erectile function, and it is known that all diabetic men have erectile dysfunction. You can measure that. I would also say that every man after 50 years of age has a little bit of erectile dysfunction. This is just physiological. And it's a sign of arterial deterioration, if you wish, but this is the way it goes. So the idea was to study the chronic treatment with vardenafil in type 2 diabetes mellitus, and these are the results of a clinical study that we performed in the last few years as a monocentric study, placebo-controlled, randomized, non-sponsored by the industry. This study has been just published in the European Journal of Endocrinology, which is not the New England, I admit that, but is one of the best we may have. And and I take this occasion to acknowledge the contribution of all the co-authors in this study. So the study design was a longitudinal, prospective, randomized, double-blind, placebo-controlled, investigator-started, non-sponsored clinical trial. I do not know whether anyone in the audience ever embarked in such an activity, which is really very, very difficult to conduct. But I think this is the way science should proceed, and at least should start, because this is independent research. The study design included an enrollment phase and then a treatment phase with 2 tablets of vardenafil, that is Levitra, in the morning and in the evening, controlled against placebo. And this is the first study that has used this drug continuously for 6 months. And that's the reason why we had so many visits, at least at the beginning. And after 6 months of treatment, the patients were withdrawn the drugs and were followed up for further 6 months. The inclusion criteria were only diabetes mellitus diagnosed in the last 5 years. So of course, they had to be males, because otherwise would have been off-label, and that caused a lot of troubles in this country. Age between 40 and 65, not too obese, and mild to severe erectile dysfunction. That was not a problem to find. And the exclusion criteria, the absence of systemic diseases, psychiatric disorders, and all the contraindication of PDE5 inhibitors. The endpoints, what I told you before, as an hemodynamic parameters, flow-mediated dilation, serum biomarkers, we choose ICAM and VCAM1, and markers of inflammation, interleukin-6, and highly sensitive C-reactive proteins. And since we are reproductive endocrinologists, we like testosterone, and we decided also to measure testosterone and gonadotropins. This is the flow chart of the study. We ended up in the end with 20 patients which finished completely the study in the study group taking vardenafil, and 22 patients in the control group. But these patients could be fully analyzed. The flow-mediated dilation, I don't have to explain to you. You know exactly what it is. And the results showed that with this intervention, we had no significant difference in the flow-mediated dilation in basal conditions, but a significant improvement in flow-mediated dilation at the end of the study period in the verum group with no difference in the placebo group. So the chronic administration of vardenafil improves arterial function and vasodilation in these men. The other important result was that there was a significant decrease in interleukin-6, which is an inflammation marker. And this is an effect that was seen immediately, very early after the start of vardenafil, and continued, was maintained for a long time after withdrawal. So this seems to be a permanent, at least for some period, positive effect of the treatment with a PDE5 inhibitor. Other markers of inflammation, CRP, ICAM, and VCAM were significantly related to interleukin-6, again suggesting a positive effect of markers of inflammation. But the most important or interesting thing for us, andrologists, reproductive endocrinologists, was the effect on testosterone. Testosterone overall did not change in the patients, in the placebo and in the control group, but when we took only the subgroup of patients with subnormal testosterone levels, which is below 10.4 nanomoles per liter according to the cutoff of the Endocrine Society, then we had a few hypogonadal patients who were not treated with testosterone and who only by treatment with vardenafil had a significant improvement in testosterone levels compared to baseline at the end of the treatment phase. And this situation, so they reverted somehow hypogonadism due to vardenafil with an increase of endogenous testosterone, and they reverted to the baseline situation at the end. What is the mechanism? We don't know, but it has been reported by others sporadically in the literature. It could be that the vasodilation induced by vardenafil in the testis improves blood flow through the testis to the Leydig cells, producing more testosterone. The other possibility is that the inhibition of cyclic nucleotides is not only on cyclic GMP, but also on cyclic MP, which is the second messenger of gonadotropins, and it is cyclic MP that in the end increases testosterone. Of course, the patients were very pleased. The compliance in the study was very nice. There was a small placebo effect, of course, also in the placebo group, and an increase and improvement on all sexual functions that could be measured, which was a nice compliance, as I said, measurement. But these are the results on endothelial function. So endothelial dysfunction is typical of chronic diseases, although there was no time to go through all of them. And the PDE5 inhibitors treatment have no adverse effect on cardiovascular health. This is known from the literature and also known from this study, as I told you, the first with 6 months continuous administration and no side effects. So chronic vardenafil treatment is safe in diabetic men. Of course, it is not ideal because it is 2 tablets a day because of the half-life of vardenafil. Tadalafil would have been much better, but there was no interest of Eli Lilly to perform such a study because they sell it anyhow. So why to bother? PDE5 inhibitors improve endothelial health, in particular improving FMD and decreasing interleukin-6. And in hypogonadal men, vardenafil improves testosterone serum levels if the men are hypogonadal and diabetic. There is a bunch of other data looking at the adrenal steroidogenesis that there's no time to show today, which show interesting results also there. I think even if PDE5 inhibitor research is somehow confined to a small group of people who are not able to perform big studies, these drugs would have a great impact and deserve more attention. And those of you who don't use it should do it. Thank you very much for your attention.
Thank you, Manuela. First question. Second. Gullo.
Thank you very much for this very interesting study. Three quick questions. Did you check insulin sensitivity in these guys? Second, did you measure testosterone binding proteins? And third, obviously I don't need it, but may I sign up for the control group of the next study? Thanks.
These patients were diabetic type 2 with different type of therapy. They were most of them only under oral anti-diabetic drugs, a few of them also insulin. During the study, the drug consumption, glycated hemoglobin, the glucose levels, and the glucose tolerance did not change. So, no, we did not do it, but we could do it. We could measure insulin because it would certainly be a much better, we have the sample, so we could do it. SHBG was measured, of course, did not change. There was a behavior which was parallel for free testosterone, like total testosterone. Testosterone was measured by mass spectrometry here, so it is pretty robust. And there is no more information with SHBG. And of course, I will take your name for the next trial.
Your talk was fascinating. I saw in your graph the rage as being a central point. The reactive, the receptor for active glycation end product.
Yeah.
And the reason why I bring it up, it's in COPD and emphysema, there is a direct relationship between rage levels in tissue and emphysema. And the soluble receptor, which is a decoy, when it is up, is associated with less emphysema. Why didn't you measure rage, or S-rage, which is soluble?
I mean, if it can be measured, if it can still be measured in stored samples, we could do that.
Okay.
If there is a method available, it was not in the middle of our interest, but certainly something that could be done.
Okay, and then because when we did our comorbidome in 1,600 patients over 10 years, erectile dysfunction was highly prevalent, but it was protective for survival. And I think it's because they're taking PDE5 inhibitors. So there may be a link, a positive link that we should explore between rage, inhibitors of rage, and survival.
Okay, thank you very much for this suggestion. I think this is very important. And actually, nobody really knows what is the real usage of PDE5 inhibitors because people do not admit to do it. And there is a huge market also in the internet of this kind of drugs. And of course, all our studies could be somehow could be a little bit dirty because you don't know whether your patients are taking these drugs. And they have certainly an effect on the general vasculature. So it could be even a positive effect for COPD.
I'm going to follow his advice.
Okay.
Do you have any tablets left?
And then, I plan to take them for my husband. But that was... But that is not possible according to the regulations of the Italian laws in drug experimentation. So they went back to the pharmacy and they were destroyed.
Can I just ask you a question about whether you detected any vasodilator effect? I thought you were doing some measurements.
There was flow-mediated dilation. Yes, that was significantly improved. Okay.
And is this effect through nitric oxide?
Probably yes.
In your experiment?
In my experiment, I don't know, but the entire background is that there should be an increase in nitric oxide as it is demonstrated in experimental animal models by using these drugs. And this is the mechanism through which PDE5 inhibitors improve erection. That has been demonstrated in many studies. Not here, but in many studies before.
What do you know about the effect of PDE5 inhibitors in patients with pulmonary hypertension in terms of erectile dysfunction?
Personally, nothing.
And from the literature? Because I asked always our patients treated with these kind of drugs, and they ever said no effect at all.
You should ask the wife.
Yeah. Next time.
No, but seriously, I'm always suggesting my society, which is a society of andrologists, to perform a study with PDE5 inhibitors, not asking men, but asking the women whether they notice any difference. And if you do that in a placebo-controlled fashion, I think that would be extremely interesting.
Manuela, thank you for the presentation. I understand that the doses used in pulmonary hypertension are much higher. Am I right? I mean, for prophylactic,
I don't
you
know.
use...
You are the expert of pulmonary hypertension.
They're much higher.
Yes, they are higher. They are higher, yes.
The order of hundreds per day.
Last question, yes.
It's really fascinating. Did you see any can I go Italian?
Yes.
I went blind. And, effetto di saturazione or...
No, we didn't measure that. What do you mean by saturation effect?
I mean, what you do when you infuse...
plateau.
Yes.
Well, no, I mean, after a few days of infusion of a nitrate...
No, we didn't do that. No, we didn't do
No,
that.
no, help me.
The ceiling effect of the drug.
The tolerance, yeah. Yeah. Did you see any
Tolerance.
tolerance effect in these people?
On which...
Because diabetic people has low concentration of disulfide donors, so...
Yes, no, there was no tolerance.
Thank you.
No.
Okay. Thank you very much to everybody, to the speakers.